Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey, friends, welcome to this week's episode of the Healing Pain Podcast, where we're talking about chronic pain in children and adolescents. My guest this week is Dr. Anabela Silva. Dr. Silva is a physiotherapist as well as an adjunct professor and the director of the physiotherapy program at the University of Aveiro in Portugal. Her research interests include the effectiveness of pain neuroscience education, exercise, as well as the exploration of factors associated with the onset of pain and the maintenance of pain in children as well as adolescents. On this week's episode of the podcast, we'll discuss some of Dr. Silva's recent investigations regarding pain and children and adolescents. We'll discuss the specific factors associated with the onset as well as the persistence of musculoskeletal pain in children and adolescents, as well as how to assess and identify these factors at an early age. Okay, without further ado, let's begin and let's meet Dr. Silva and learn about pain in children and adolescents. Hi there, Anabela. Welcome to this week's episode of the Healing Pain Podcast. It's great to have you here.
Hello, Joe. It's my pleasure to be here. Thank you for inviting me. And I'm very excited to have this chat about the importance of looking at the factors associated with chronic pain in adolescents.
Yes, we're excited to have you here as well. We try to reach out to a broad range of professionals, especially physiotherapists from all around the globe. You're probably our first expert speaker from Portugal. So we're excited to bring that international collaboration to this. And the other thing that we're really excited about here is to talk about musculoskeletal factors that impact children and adolescents, because there's not a whole bunch in the literature still. It's still relatively new, I think, as over the last decade, as the chronic pain research in general has started to rise in adults and non-cancer pain. We're also seeing the literature rise in children and adolescents, trying to figure out the biopsychosocial factors that impact them and what processes we can change in our patients. What's the importance of knowing those factors that are associated with pain at an early age?
You are absolutely right. So the amount of literature that is out there looking at children and adolescents is not that much compared to adults. But contrary to common belief, pain and chronic pain, in particular musculoskeletal chronic pain, is actually high in these age groups. Actually, if we look at the late adolescence, the figures can reach pretty much the figures that we see in adults. In addition to that, some of the painful conditions have actually been raising in terms of prevalence in the last decades. For example, if we look at neck pain, there is the literature shows an increase in terms of prevalence for neck pain in this age group. We also have to consider the impact that pain has at age group, and we know that impact not only the relationships with the family and the peers, but also, for example, school attendance and school grades. And in addition to that, we also know that having pain when an adolescent increases the odds of reporting pain when adult. And interestingly, there are some reports that actually show that having pain adolescent increases your probability of being a less successful adult, for example, in terms when looking at socioeconomic status. So really, in this age group, pain is not only highly prevalent, also has a current impact, but also a long-term impact. So knowing the factors that affect pain also helps us when designing preventive interventions and management interventions that hopefully, if they are directed at the needs and characteristics of these age groups, will at least have the chance of being more successful.
Right. So the work that you're leading and the work other researchers are leading, looking at pain in children and adolescents, helps us to gain some clarity around ways we can prevent pain from an early age, ways we can identify pain in children and adolescents so we can treat it early. And if we can prevent, identify, treat early, then we can prevent its persistence into adulthood, which leads to really poor quality of life and resilience and poor growth in adults, it sounds like.
Yeah, exactly. So it's really important not only for this age group, but for helping in terms of transition into adulthood and minimizing the impact of pain in when adult.
So the word factors is thrown around a lot. You hear it in research, you hear it on the news. Maybe you can give us an overview of the factors that are starting to rise to the surface when we're looking at the severity and the maintenance of pain in children and adolescents.
We have conducted a number of studies looking at the different factors, some of them are with a more biomechanical nature, for example, posture or physical activity, but also psychosocial factors. And actually, our research and the research in general shows that psychosocial factors and factors such as sleep, for example, tend to be more relevant, or at least explain a little bit more of the variance and of the probability of reporting pain at a later stage, and also explaining the high levels of pain and associated disability. Among the factors that we have studied is, for example, the time spent in terms of using a computer and other technologies, also physical activity, sleep, psychosocial factors such as self-efficacy, also fear of movement, for example. And in our later studies, we have also looked at symptoms of central sensitization, which is something that has been explored in adults, but not in adolescents.
So you mentioned early on, postural factors and more factors related to physical capacity, so to speak. Do those play a role? I mean, obviously in the research, psychosocial factors, we know what they are at this point. And I think you're really mapping those to children and adolescents. But do we just kind of throw out the biomechanical factors in children and adolescents, especially since they have growing skeletons and a growing human body?
Well, in the research that we have conducted, and we actually conducted a systematic review looking at the factors associated with pain, including the more biomechanical factors, and we found no association between pain and posture. We have to look at the evidence with reservations, because the quality of the studies was not very good. But the evidence that we have shows that posture is not a particularly relevant factor in terms of pain, both pain intensity and pain maintenance in terms of long-term probability.
So these factors that we're talking about, is there a difference between the factors of onset of pain, so why pain begins, versus the ones that cause pain to persist or become chronic, which would be those that typically persist more than 3 to 6 months?
Well, I would say that there are similarities and differences. There are some factors that tend to be common to both models, to the models that explore the association with the pain that I feel now, also with the odds of reporting a new episode of chronic pain. It's quite difficult to map the research, including our studies, with previous studies, because the variables that have been studied are relatively different. So this is really difficult to show. But in general, what really seems to emerge from the research is that psychosocial factors are relevant, both in terms of the pain that I report now, the disability associated to that pain, and also the odds of reporting pain in the future. However, in this study that we have conducted, looking at the factors that are associated with a new onset, it was we were a little bit puzzled, actually, because the only factor that remained in the model were symptoms of central sensitization, which include actually some questions that cover some psychosocial factors too. So this might have been one of the reasons.
So I'm just curious, we're talking about children and adolescents, and that's a broad term. And we're identifying that pain does become persistent in children and adolescents. Have we identified at how young of an age this can begin? I mean, barring things that are cancer, obviously childhood cancer could cause things like chronic pain. But if we're just looking at musculoskeletal pain, or what all of us as physiotherapists would identify as musculoskeletal pain, do you have an idea how young of an age that really can start and when we start to see this?
We in our group, we have not looked at that particularly. We have worked mainly with adolescents ages between 15 and 18 years old. And our samples were not that big. But what we found is that almost half of the adolescents in a follow-up of 6 months still report pain. And approximately 40% of those that didn't have pain will report pain at a follow-up of 6 months. So the figures are really high, at least in our studies. Whether these figures are actually similar when we look into younger groups is not something that we have looked into.
Fascinating. I'd love to hear some research around that to see when we really should intervene. Like, how young should we be intervening and trying to educate children and their caregivers on factors that can cause, obviously, pain to persist. The thing you have identified in your research is that neck pain has come up as one region where the adolescents report pain over and over and over again. Are there other regions that we should be aware of other than neck pain?
Yes, neck pain is quite interesting because when we think about the most prevalent painful body site, we tend to think of low back pain. Mm-hmm. And what our research has suggested is that actually when we look at these age groups, neck pain comes first. And also when we look at the evidence that is out there, there's a very nice systematic reviews whose authors, unfortunately, I can't remember the name, but they looked at the prevalence of neck pain at these age groups over the last decades. And there is a constant trend towards the increase of neck pain prevalence. And low back pain comes second, actually. Low back pain, thoracic pain come second to neck pain. The other thing that it's actually similar to adults is that most adolescents do not report pain at a single body site. They tend to report pain at multiple body sites. What again is quite interesting. And one of the studies that we conducted looked at the association between painful body sites, especially when you also take into account psychosocial factors. The results suggest that having a painful body site is more important in terms of association with other painful body sites than psychosocial factors, suggesting that it really is important to prevent pain, because once you have one painful body site, then there is a tendency for the pain to spread. What we know from the neurophysiology of pain, that is something that is easily explained, but I would say that it reinforces the need for knowing more and designing and assessing the effectiveness of preventive strategies targeting this age group.
You mentioned, so the age group you're studying is about 15 to 18, so teenagers, adolescents.
Yes.
What should we start to look at with regard to the school setting? Because obviously that can be, the teen years can be a stressful time for students. There's a lot of change happening in their life. There's a lot of change happening in their physical body, which might lead us to think, well, maybe there's more actually of a neurophysiological event that's happening, because puberty does involve a number of hormonal changes, so we can't ignore that. But what factors are associated with pain in the school setting?
All those factors that you have mentioned are very important, and looking at puberty stages is quite important, although it's a little bit difficult to implement because of the tools that are the ones that we should use to assess puberty levels are not easy to use. But in addition to that, I would say that looking at the family, for example, at the history of the family in terms of pain, is something that is likely to be very relevant. Looking at self-efficacy in general, for example, also genetics clearly also plays a role here. Looking, for example, at sensitivity of the nervous system in general, not only related to pain, might be something that also is relevant. Looking for other complaints, for development in general, might be factors that impact or at least change the probability of reporting pain. we are now designing a study looking and exploring a little bit more of these factors that we have not taken into account in our previous research, and exploring whether these factors adding to the psychosocial variables are able to explain a little bit more in terms of probability of reporting pain in the future.
Is there anything else that we're missing? Obviously, along the life course of a child and adolescent, there are many things that come up. Anything that we're missing if a parent is listening to this and they have a child maybe who has pain and they're saying, oh, okay, psychosocial factors. What does that really, what does that really mean? And what can I walk away with, let's say, from this episode with regard to helping their child or their adolescent find obviously a cure? We don't want children to suffer and be in pain, a cure for their pain.
Well, I would say that it is probably important to listen to them, to pay attention, to not too much attention either, because we know that it also impacts. This is actually a tricky question in terms that we are not actually sure that how parents should behave and how parents' behavior actually impacts pain. But one of the things that we came across when recruiting students for our studies is that in general, people believe that they don't have pain. This is an age group that is perfectly healthy and okay. So I actually had a few people asking me, why are you studying pain at this age group? For sure, they don't have pain. So listen to them, listen to trying to understand how they feel, both in terms of pain, but also in general, in terms of whether they are stressed, they are anxious, whether they are actually behaving in a way that is adjusted also to their pain, trying to find whether they are not doing some of the things they would like to do or that are normal that adolescents do, and they are not doing them because of their pain. I would say, actually, from both, also from a parent perspective, that we do need to listen to what they say, and if we find that appropriate, to just look for a professional advice that can guide us as parents to help them, both in terms of how we are addressing their complaints, but also someone that can educate our children and can design and help them self-manage their pain also.
It's interesting to think about the feedback that you receive, that why are you studying pain in such a young demographic, which makes us think that when people say that, they're thinking that pain only exists in people who are middle-aged or older, when in fact we all have a nervous system, and sometimes that nervous system becomes overloaded, and the outcome of that could be chronic pain of various sorts.
Yeah, it was quite interesting, but it was also quite interesting, and I found that recruiting adolescents at the school setting was also a form of raising awareness, because a few weeks later, the same persons would come and say, well, now that I have paid a little bit more attention to them, I've actually realized that some of them are in pain, and that pain is actually interfering with some of their activities, and so it really is a way of raising awareness for pain at this age group, so that people pay a little bit more attention and can ask for help when appropriate.
What are the clinical implications for physiotherapists and other practitioners when you start to put the pieces of your research together for them?
Well, I think the overall key message would be that pain and chronic pain is actually a considerable, is actually achieving prevalence rates that are high, despite this common sense that they don't have pain. The other would be that we need to look at the person in a whole person approach, instead of looking at a single body site in a biopsychosocial approach. So we do have to look to the person, not to the complaint or the body site where that complaint is being reported to. So this would be the two main things. Then that there are key factors that there seem to be key factors that actually are relevant. For example, the anxiety or fear of movement. Sleep seems also to be something, an important factor in terms of pain maintenance that should be part of our regular assessment of this age group. And in this later study where we looked at the factors associated with pain onset seems to suggest that finding a tool that allows us to assess the sensitivity of the nervous system in general may also be a way to screen for those with a higher probability of reporting pain in the future. So I would say that is probably something that we need to consider when both assessing pain and its implications and also when designing programs aiming at prevent and manage pain in this.
Yeah, that was a question I had way back earlier in the episode here in our interview, because you mentioned central sensitization. I'm not sure which self-report measure you use, but I can't think of one that is validated for children. Is that something that we should start to look at in our research, or do we have that tool already?
We have actually used the central sensitization inventory, and we have validated it we have translated the English version to Portuguese, and we have validated it in this age group.
In a Portugal population.
Yes, but we know that central sensitization inventory has some shortcomings, if I can say it that way. So it's not a bulletproof instrument. It gives some indications, but we know that it is also associated with psychosocial factors, for example, and it might. So what we are now looking at is we are designing a study where we are going to use quantitative sensory testing, which is a bit harder to have a larger sample with using quantitative sensory testing. But this is something that we are now looking at, and we are also exploring the association in this age group between the central sensitization inventory and KST measures. So that's why I was saying earlier that we need to look very cautiously at our results, because they do have some limitations, and using the central sensitization inventory is one of them, though it's a very practical tool that gives some indications. When we look at the items, we actually used both the total score of the instrument, but then we looked at the items that were more strongly associated with the probability of reporting pain in the future. And there were 3 items. 2 were more linked to the psychosocial aspects, and there was another item that is the item related to memory complaints, and those that reported pain at the long term reported more difficulties with memory
and learning, which is important for children.
Yeah, which exactly is really important at this age group. Yeah. So we are now looking at more general central sensitization instruments and trying to see how they relate with the central sensitization inventory, and whether when looking at those instruments and using those instruments, these associations are still in place, or there are other associations that emerged from the data analysis.
Yeah. So as I sit here in the United States and you're there in Portugal, I think we should really touch on the question as to the research that you're finding in that particular age range of 15 to 18-year-old adolescents. Is that consistent in what we would consider, quote unquote, the Western world, as well as maybe third world countries that might have other factors that are working for or against the persistence of pain? And what does the research say about that?
Well, the research that is out there shows high prevalence, though the figures that have been published are slightly lower than those that we have found in our studies. Not sure how this can be explained, whether it has to do with it's more of a cultural thing, it's more of lifestyle. It's more related to the lifestyle of the adolescents that might be different across countries and certainly across continents, but the results are not that different, but the figures in terms of pain prevalence and pain reporting in terms of long term are slightly lower in the studies that are out there when compared to our figures.
Or it also makes me think in certain countries is access to care different, which might impact the statistics that we see in that particular age group.
Yes, that might be one explanation. The other explanation might be methodological, because in our studies we asked we ask a question for each body side. So we clearly ask whether do you have pain in the neck and in the shoulder and in the low back. And some of the studies use more general questionnaires. So the methodology is not exactly the same. And this is also another explanation for the results that we see. But certainly that is the question that you are raising is really very important, looking at whether different cultures, different lifestyles, different access to care has an influence on these results. That is really something that is very, very interesting.
Anabela, thank you for joining us this week and telling us about your growing research around the important factors associated with pain in adolescence. It's an area that we will continue to follow because we obviously need more research in this area so we can help children, adolescents, and their families in the school settings that they function in. If people want to learn more about you and your work, how can they follow you?
Thank you again for inviting me. If people want to learn a little bit more of what I have been doing, they might find me in ORCID, also in Scopus and in Facebook. And they can also email me if they want a little bit more detail about some of the studies that we have been and are conducting.
Great. So we will include all those links. So if you're interested in Anabela's work, you can reach out to her. To find those links, all you have to do is go over to the website at the Integrative Pain Science Institute.com, go over to podcasts and scroll down to today's episode. And you'll find all the links there down at the bottom of the page. You can also follow me on Instagram. My handle is at drjoetatta.com, where I post all of our podcasts and little snippets of the videos that we record together. So make sure you hop on over there. If you enjoyed today's episode, take a screenshot and tag me on Instagram, and I'll make sure to tag you back. I'm Dr. Joe Tatta, and I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.